Today we will deal about approach to a case of COPD, especially acute exacerbation of COPD. Most commonly, the individual will present with dyspnea which is worsening since last few days, or there might be cough, etc. And often they will be elderly, smoker or previously a smoker, with past history of admissions for similar complaints, like already a known case of COPD, or you can consider the history of usage of inhalers. So this time the acute exacerbation might be because of many reasons, but most common among all will be infections. Infection is most common. Other reasons might be disease progression itself. So disease progression or non-compliance to medication, non-compliance, or even some new onset cardiac abnormalities, especially heart failure or even acute coronary syndrome and even arrhythmias. So these might have led to acute exacerbations. Here, never forget to consider infection as the most common cause for aggravation. Then we have to assess for some initial important parameters such as saturation, BP, pulse rate, because if there are any cardiac anomalies, we will get in these things, and saturation will help in assessing again the severity of presentation. These are few things, and auscultate respiratory system quickly so that we will get some picture about the presentation. Then we can consider giving injection hydrocortisone 100 mg IV stat, and if saturation is low, supplement with oxygen to keep target saturation of about 88 to 92%. Then give nebulization till the acute worsening settles down. Here, as we have told, commonest reason will be infection. So once the individual is settled to some extent, send for chest X-ray. So here mainly we will be looking for the features of infection as we have listed out. So among infection, better to cover with azithromycin or any other macrolide. This will not only cover the most common organisms causing acute exacerbation, it will also cover some atypical organisms such as Mycoplasma, Legionella, etc. And if we get some opacity bilaterally, so if it is bilateral disease, please consider adding antivirals, especially oseltamivir, because it is very common in viral infections to get bilateral presentation, and majority of the times bacterial pneumonias will be unilateral. This is common observation, not a rule. So after this initial settlement, we have to observe for few important clinical examination before sending for investigation, especially about CO2 retention features or CO2 narcosis, increase CO2. Just don't rely on ABG, sending ABG, because again it is a costlier investigation which is not affordable by many Indian patients. So please consider checking for clinical signs of CO2 retention, such as from head to toe. If we consider, ask for headache, then blurred vision, even increased daytime sleepiness or drowsiness. Through fundus, observe for papilledema. Peripheries, if we feel they will be warm and there will be bounding pulse. So these are the features of CO2 retention. Then assess for any features of pulmonary hypertension. For example, look for palpable P2 and dullness in left second intercostal space on percussion, any parasternal heave, even epigastric pulsations. So these will give a clue towards pulmonary hypertension. So one of the presentation of pulmonary hypertension will be like, individual will have very much low saturation. For example, they will have 30-40% saturation at room air, and if we supplement with just 2 to 3 liters or 4 liters like that, minimal supplemental oxygen, saturation will drastically improve. So that will be a feature of pulmonary hypertension which we have to keep it in mind. So these things have to be assessed clinically before sending ABG and 2D echo here. So this is one more important add-on point. Later on, once we have started with the initial management, just observe for 2 to 3 days. If the individual is not responding in 2 to 3 days, please consider change of antibiotics, especially if we have sent sputum or culture sensitivity, so change it accordingly. Otherwise, we can just escalate to some other higher antibiotics. So this is one thing. And in these 2 to 3 days, we have to keep on observing for the clinical assessment. That is, how is the patient clinically, whether improving or worsening or remaining same, and how is the infection getting controlled. So for that, we need a repeat complete blood count. So at least these things can be monitored to look for improvement in patient. So we will consider change of antibiotics. Suppose there is no improvement even after this, even after some another 2 to 3 days, we have suspected infection or some other reason as the risk factor for development of acute exacerbation in a case, and we have started with all the necessary things, but the individual is not responding over even after 5 to 6 days. So then we have to consider sending D-dimer, because chronic pulmonary thromboembolism will mimic like pneumonias, that will mimic like acute exacerbation of COPDs. So, but one should have a very high suspicion about pulmonary thromboembolism. So, if the individual is not responding, or we can consider in general, if the respiratory case is not responding to the initial management in some 4 to 5 days, always consider pulmonary thromboembolism. So please send D-dimer. If it is elevated, we can consider further workup using CT pulmonary angiogram and all. So this is the basic thing when we deal with the case of acute exacerbation. And once the patient is stabilized and all, it is very, very important to guide the individual regarding the medication usage, especially if they are using any inhaler or rotahalers. Please show them the technique. Please demonstrate them. Then it is again very important to assess for the dosage. Individuals who were responding previously to low dose inhaled corticosteroids might require moderate dose, or some might even require higher dose, or sometimes the frequency is not adequate. So that things should be assessed, and please advise about smoking cessation and some pulmonary rehabilitation things such as some minimal stretching exercises, even chest physiotherapy and spirometry, etc. And these individuals, if affordable, please advise for some vaccines such as pneumococcal vaccine, Haemophilus influenza, and the flu vaccine should be advised for COPD patients, especially those who are getting repeated exacerbations. So this is the common approach to any case of COPD. To summarize, whenever the individual presents with sudden onset breathlessness, just look for infection features. In that, you can ask history of productive sputum or productive cough and fever episodes. Some other risk factors should also be assessed. And then look for some vital parameters, especially saturation, BP and pulse rate, because this cardiac status is very, very important, because some medications will have correlation. For example, if the individual is having tachycardia, it is generally not advised to give salbutamol nebulization. Similarly, if the patient is having some underlying cardiac disease, and if they are using beta blockers, again, that might lead to bronchospasm. That have to be kept in mind like that. So medications will play an important role. That's why underlying cardiac status is very, very important. Then for the acute breathlessness, we can give hydrocortisone, IV stat, then give supplemental oxygen, give nebulization, send for chest X-ray, look for any features of infection. Then based on that, try to cover the antibiotics which will cover maximum number of microbes. After that, after initial settlement, after 2 to 3 days, assess for the improvement. If there is no improvement, please consider change of antibiotics, and even then, if the individual is not responding, consider other possibilities, especially pulmonary thromboembolism. Meanwhile, in all cases of COPD, always assess for CO2 retention and pulmonary hypertension. Hope you have got the case approach. Thank you so much.